All right, well, welcome to our American Heart Association ERC Guidelines Launch 2025. This session is going to cover both systems of care and ethics. The first part of the session will be covering systems of care, and the second part will be covering the ethics session. We have an opportunity. Welcome to those joining us online. There's an opportunity for you during the sessions to ask questions. So there's a checkbox or a question mark you can click on to ask questions, and we have someone collecting those questions, and they'll bring those forward to our panel. I want to also introduce my co-moderator, Rakesh Garg, from the Indian Resuscitation Council Federation. My name is Bob Newmar. I'm from the American Heart Association, and we're both volunteers for the International Liaison Committee on Resuscitation. And with that, I will let our first group of panelists introduce themselves and begin their session.
Okay, well, thank you for that, Bob. My name is Cameron Deswin, and I'm the chair of the Systems of Care writing group for the American Heart Association. I'm coming from Baylor College of Medicine in Houston, Texas.
Hello, everyone. I'm Sebastian Schnaubert. I'm the co-chair of the Systems chapter for the ERC, together with Federico, and I'm from Austria.
Hello to everybody. I'm Federico Semeraro. I'm the co-chair with Sebastian about the System Saving Life chapter for ERC.
Good morning, good afternoon from wherever you are. I'm Jose Cabañas, Vice Chair for the Systems of Care writing group with the AHA, and I'm an EMS, Emergency Medicine Doctor at Raleigh, North Carolina. Thank you all for being here.
And I think importantly, no one within this writing group has any disclosures that are relevant to this. So we just want to introduce the topic that we're going to be going over and also the areas of focus. Obviously, our two writing groups covered a tremendous amount of material, more than we can possibly encapsulate into 30 minutes. So we chose to really try to focus it. I think that, first of all, we want to highlight the importance of systems in resuscitation and the way that systems guide how we do our different processes and the impact on policies, on government, on community structures. The areas that we're going to focus on is to start with the chain of survival. We have a slightly different chain for the US and the Europeans. We're going to talk about the response to out-of-hospital cardiac arrest, and that goes everything from the community to EMS providers and telecommunicators. And then finally, we're going to move on from pre-hospital to post-hospital and talk about cardiac arrest centers. So the next slide there that you'll see is poking the bear, right? And this is a concept which, if you're not American, you may not be familiar with, but it's the idea that we're purposely going to put into our material some topics that, we're trying to make it a little bit controversial, a little bit of a back and forth, and we want to stir up some conversation, right? So the idea of poking the bear is just, you maybe you're getting into a little bit of trouble, but hopefully it's a kind bear. So, we're all very happy bears here. I think we'll get along quite well. So with that, we will move on to our chain of survival. And so in the US, the AHA's chain of survival actually has become much more simplified this year compared to our last iteration of guidelines. So in 2020, there were 4 chains of survival for pediatric and adult in-hospital and out-of-hospital cardiac arrest. And in looking at it in this cycle, the systems of care really led the charge, I think, in talking about how it just made sense to have one chain. And that one chain was meant to encapsulate all the steps. I think that the different features of the chain ultimately are roughly the same between the US and the European Council, but we've chosen to kind of divide ours out more. And the one thing that I'll say that is missing from our chain right now, but it's something that we plan to put back in subsequent years, is the concept of prevention and preparedness, which I think is the first step of the chain of survival. Is if you can avoid cardiac arrest altogether, that's the best thing possible. The other links of the chain, recognition, activation, the actual resuscitation, both compressions and AED use, the post-resuscitation care, and finally the survivorship are things that I think are common with our European colleagues.
Right. So if you recall the last guidelines, the chain of survival wasn't really specifically in the guidelines anymore, in the ERC guidelines. So we kind of reinvented, reintroduced, refound the chain of survival for our guidelines here, and this is the new version. It's rather similar, as you said already. We have only 4 links. That's because we combined links. So the contents are basically the same. We have a similar emphasis on survivorship, which is also a new, or rather new concept, I think, at least that it's in the chain of survival. And the prevention, of course, is as important. In between, you have ALS and BLS together and post-resuscitation care in there just to depict the whole chain that's, well, applied. And one rather important topic that's also kind of in there in the chain of survival, but in the ERC guidelines in all of the chapters, is the low resource settings. So we have put an emphasis on low resource settings or resuscitation in low resource settings that can apply to all kinds of, well, income countries, low income countries, high income countries, all of them can have low resource settings, and we have applied this to all of our chapters and also to our chain concept, I would say.
Yeah, and I will say that that's one of the areas we're going to talk about as we go through our discussion here is some of the really cultural differences, I think, between Europe and America. And one of them, which I admire Europe for, is the thought of the whole world as a global community, right? And I think America is a little bit more inwardly focused right now, and so that doesn't always come through, nor do some of the ideas with community involvement, which I think you guys are going to get to.
Yeah, I agree, Cameron. This is an example. So community response to out-of-hospital cardiac arrest. In Europe, we have an extended community all over the country, all over every region that produce like a community of first responder, community first responder. In many European countries, they have an app that they engage the first responder, the lay responder. So basically, our recommendation was, in the second point, based on ILCOR. But yes, we extend around ILCOR the concept that the community, it's like an alliance between healthcare professional and the community. So basically, we want to advocate to the European citizen, to European Union and beyond, please help us to save a life. This is our message. So this is the reason because we put a lot of emphasis on first responder.
Thank you. I think from the AHA guidelines, I would like to highlight that in the same way the European guidelines and the AHA guidelines, I think you can palpate the deep sense of community. And I think when you look at the sort of this version of the AHA guidelines in this SOC chapter, in the past, we've had sort of the elements of what the community represents to respond to cardiac arrest in different parts. And I think we tried, the writing team here, tried to sort of bring it together in a more consolidated fashion. So acknowledging the mobile technologies to some responders to cardiac arrest events is reasonable to sort of enhance that late rescuer participation and to apply AEDs in a more timely manner. But it's also reasonable for communities to implement policies that require CPR certification for general public. And I think we tried to collapse this into sort of one sort of bucket that represents community as that critical element of the chain of survival. And I think as our colleagues in Europe have shared, they have it, their sense of community has a little bit more advanced than where we are. But I think we want to make sure that we acknowledge the criticality of community as we try to broaden the response for patients' cardiac arrest across the diverse communities.
Yeah, and this is one of the areas, Jose, I think you would agree with me, that compared to Europe's language, ours is much more soft, right? Yeah. Europe basically says first responders, and when they say first responders, when you say that in America, you're thinking EMS. When you say that in Europe, you're thinking of citizens going into people's homes and doing resuscitation, right? And that's a big cultural difference, and I think an important one, which is why our guidelines are not nearly as forceful in saying, get the community in there, teach all the kids how to do CPR, whereas the European language is a lot stronger, and I think that's really to their credit.
Yeah, and I think we've done a good job of trying to sort of consolidate sort of the message into a more sort of more specific recommendations, but still we have a lot of work to do in that space.
So tying into this, as you've said, getting people into people's homes and helping them and performing CPR, sorry, we have to talk about EMS and the EMS response to out-of-hospital cardiac arrest. And we differ in a few things, I would say, between Europe and America. We have a very, very strong recommendation now that all ambulances going out there have a defibrillator. This hasn't been the case so far. This goes along with the European legislation or a recommendation by the EU. And a second quite new thing, I would say, is critical care teams in the out-of-hospital setting, the pre-hospital setting. We haven't had this. So an ambulance is not good enough anymore. We really want experts and professionals out there. We really want critical care teams out there, not just a paramedic or something. So what's that like in your guidelines?
Yeah, I mean, I wish, as an intensivist, I wish critical care physicians were more involved in pre-hospital settings, but they're really not. They're completely absent. And, you know, there are some emergency medicine and critical care trained people. Bob Newmar is actually one. Jonathan Elmer is another. I'm looking at both of them. And so they understand this field better than anybody. But the reality is we don't do a great job getting our critical care community out into the resuscitation space, where I think they could make a big difference.
Yeah. Oh, finish.
Go on.
No. I think this is a great conversation, and I think in the spirit of, even though the delivery of clinical care in the other hospital setting philosophically varies by settings when you look at Europe and the United States, and some of that is how we have structured our teams and who is the resource available to respond to calls. I think at the spirit of whether you look at the European guidelines or the American guidelines, we want to go back one. We want to make sure that we're delivering sort of the right care and the proper care that is evidence-based. In our recommendations, in the sort of updated version, you will see that we have highlighted the fact that we acknowledge that there's value in having an ALS clinician sort of on scene. And I recommend sort of everybody sort of listening to this or in person to look at the knowledge chunk so you can see the evidence. There is a diversity of published evidence that is very diverse, shows sort of how many clinicians, but it's not clear how many you would need. But we think that it's critical to at least have one ALS clinician that has shown to change outcomes from a pre-hospital care delivery. And also, EMS systems and EMS clinicians must be prepared to be able to do sort of termination of cardiac arrest care on scene, but being able to have that death notification training to ensure that there's the critical communication aspects to ensure we're communicating with family properly. I think that's something that we have more intentionally compared to prior years sort of acknowledged in this version of the guidelines.
Absolutely. And I think all this could be summarized, well, if we want professionals out there, if we want individuals out there performing termination of resuscitation rules, they have to have experience, right? So what we did is we put in there that, well, EMS personnel should be monitored for low exposure of CPR. And if you, well, notice in your EMS or in your system that individuals or co-workers don't have a lot of exposure, they should be trained additionally.
Yeah. As we continue to have this conversation about out-of-hospital care, cardiac arrest care, from this version of the guidelines, actually, I'm very proud and happy about this new recommendation that we have sort of put together. The writing team sort of had a lot of energy and wrestled and had a great conversations about back and forth. But in essence, we want to make sure to acknowledge that prioritizing on-scene resuscitation, focus on achieving sustained ROSC prior to transport can be beneficial under special circumstances. I think we all know that caring for a cardiac arrest patient on scene is a huge undertaking. And we want to make sure that that time maximizes quality, make sure that we're keeping our personnel safe and not we're transporting sort of every cardiac arrest patient to the hospital, because providing cardiac arrest care during movement is just doesn't achieve quality, puts people at risk, and we miss that window to trying to maximize the potential return for circulation. Now, we want to make sure that we have an opening here because there's new emerging sort of therapies that may be in the future guiding a more structured approach on how do you move somebody from the scene early, and I know Cameron will talk a little bit about that in a few minutes, but this is a new recommendation that I think is at the spirit of the same lines with our European colleagues.
Right, we're not as far. We well, we play a little more in the stay and play concept. We say, well, when you can deliver a hospital-based intervention, you should do it pre-hospitally. So this is where we differ slightly, I would say.
I think our next topic here is going to be sort of recognition of cardiac arrest from a telephone CPR sort of process standpoint. I would just acknowledge here that both the European guidelines and both of the AHA guidelines really are solid and consistent in the fact that we want to make sure that time matters and have processes that are sort of streamlined to recognize cardiac arrest on the phone as early as possible to start intervention.
Right, and recognition over the telephone has been well highlighted greatly in both of our guidelines. This is why dispatchers should be educated and trained in it, and I think this is an area where we have some work to do. And that's why it's important that it's really written in the guidelines now, that we can go to stakeholders, go to systems and say, well, this is something we have to do now. Yeah. Well, also, talking about dispatch personnel, dispatch centers should deliver CPR instructions to people on the phone, of course. So we've had that for some time now. What's that like in America?
Yeah, absolutely. We've done sort of a lot of work trying to maximize and get the message the word out about the critical importance of telephone CPR. I think this updated recommendations in the SOC chapter, in particular, I think we're being more precise with the recommendations around infants and children compared to prior guidelines. And we want to acknowledge the fact that respiration and providing breaths is a critical aspect of that initial instruction. And I think we all know that asphyxial is sort of the main sort of driven mechanism for pediatrics, but I think this sort of recommendation provides more accuracy than prior years.
Yeah, and this also ties into one of the changes in our chain of survival, which was that the link that used to represent high-quality CPR, which only had hands before, now
Right.
also has a lung to basically demonstrate that breathing is an important part. And it's relevant not only for pediatrics, but also as we have in the US and Europe, unfortunately, a rising number of opioid-mediated cardiac arrests, and we've always had drownings. And we know that those particular forms of cardiac arrest don't do so well if you don't include the breathing. And so making that a part and making our telecommunicators try to communicate that depending on it. I think that's the ideal scenario, is that we arrive somewhere where depending on the type of cardiac arrest that the patient is having, we give differing telecommunicator instructions. That's obviously complicated, but there may be a role for AI and other emerging technologies to help with that and assist.
Yeah, for a lack of time, we speed to and we arrived to the hospital. Well, it was very nice that when we met to prepare this slide, why you in Europe are so enthusiastic about cardiac arrest center. In reality, the first sentence is from ILCOR. So yes, it's based on ILCOR, but we put a lot of emphasis around cardiac arrest center because in Europe, many European societies are working now on accreditation projects. So yes, probably is not enough evidence to support cardiac arrest center, but again, in terms of advocacy, probably we are no more sensible, but more engaged with the other European society to try to push hard and fast on the politician to create cardiac arrest center.
Yeah, and you can see from this slide that our recommendation, which is a 2B, really is at the level of an option. We're not really recommending cardiac arrest centers, and we had a lot of discussion about this. Ultimately, the reason for such a kind of mild recommendation was the fact that we could not identify what the parts of a cardiac arrest center were that made it good, right? And in fact, in randomized trials, there's only been one, but there hasn't been any clear indication of what makes a cardiac arrest center, a high-performing center. And when you look at the observational data, although all the observational studies tilt towards benefit, they all have different features, right? So is it neurocritical care? Is it having a cath lab? Is it having mechanical circulatory support? All of those in different studies has been shown to have some benefits, and yet you can't point to a single RCT to back it up, and you can't point to complete accord between these different observational studies to say what it is. So not knowing what a cardiac arrest center's components are, we struggled to say that you should have one because anyone can call themselves a cardiac arrest center. And this is also a place where I think culture is important because in Europe, you guys tend to do things more as a nation. I mean, you have a nationalized health system, so if you're going to have centers, the centers are identified on a national basis. In the US, if one company has a hospital and they have a center, well, of course, the competitor also has to have a center and they got to have a hospital too. And that becomes problematic because then the poor ambulances don't know where to take the patients, right? And I've seen that happen in several towns, and I think Jose has dealt with that as an EMS person, and it makes it challenging when we don't know clearly what is beneficial and what is not beneficial.
Yeah, but it's the same in Europe. We have Spain and Germany. They create a system of accreditation. So also in Europe, it's same behavior. So I think this will be for the future. We need definitely more evidence, more strong evidence to support and to be completely sure that this works. So from cardiac arrest center to ECPR.
ECPR. Yeah, and ECPR, is one of those areas where I think all of us would agree there's a lot of promise in the right patient population, right? But there are some struggles about who is the right patient population. So this was the first time that as a systems of care chapter, we had an entire knowledge chunk devoted to ECPR. And really what we were focused on is what are the important steps in ECPR. Part of it is making sure you get the right patient population and constantly reevaluating to make sure you're not wasting resources because this is resource intensive. Part of it is also deciding when a patient should be transported from scene with ongoing CPR because of the risks to both the resuscitators and to the patient for doing that. But if you're going to get ECPR and going to get ROSC that way, as opposed to no ROSC in the field, obviously there's a benefit. And so our recommendations were largely based around that. We did also have a little bit of guidance in there about who should be doing the cannulation. I know that at a number of institutions, ECPR is instituted by the surgeons, yet realistically, there are many studies that show that surgeons are not the best at percutaneous cannulation, and that's what's happening in ECPR as opposed to other forms of ECMO where you have time and you can split the chest open or do a surgical cut down. And so this is actually one of, I think, the important emerging areas within resuscitation, but it's one that we, as the data comes out, we're going to be changing our guidelines.
Yeah, definitely we are completely aligned on this because it's a rescue therapy. We need an excellent bystander CPR. We need a nice patient in refractory cardiac arrest to have a good chance to improve survival. And in terms of cost, yes, this costs a lot of money, so we need to find a good balance between resources and investment at the end of the process. So, to the end?
Yep. So I think we're going to get our summary from Sebastian.
Right. So to summarize, we do have, as you've seen, some slight differences between Europe and America, or our guidelines and your guidelines, applying to the whole world, of course. But the chunk of it points in the same direction, right? We have many similarities also. So as you see, of course, the underlying thing is the co-star, the ILCOR co-star, and that's not different in America or in Europe. We all rely on the same science behind it. And the thing is, if you look at regions, not only from a resource perspective, but also from an implementation perspective, from an advocacy perspective, you might have to, turn some wheels there and, well, adapt it a bit, of course. That's why there's your guidelines and our guidelines. But basically, a system, as you've seen, can produce beneficial responses also when individual components are a bit different or are challenging or more challenging in the one system or in the other system.
Okay, cool. There is some question from the audience here, or there is some question from the virtual space?
All right, well, thank you for that great overview. And we are going to our question and answer session at this time. For those online, if you look on your display, there's a question mark in the bottom right corner. And if you can click on that and you can write your question in, we have someone curating those and they can bring them forward to the group. But we'll start with questions from those attending here in person. So does anyone here have a question for our panel? Here we go.
Great presentation, and it's really comforting to see the similarities between the guidelines. I'm just wondering if maybe the reason that AHA didn't have so much emphasis on the community in the guidelines is because the guidelines are published in scientific journals that the lay rescuer is unlikely to read, but I do want to say that it is in all of our products. So there's a whole separate product just designed for lay rescuers and increasing the community response. And my COI there is I'm a product consultant for those Heart Saver products. So thank you.
Well, you know, I think, thank you for that question, Jeanette, and you're right. I mean, the American Heart Association, I think, has been very proactive reaching out to the community and trying to teach CPR and get communities involved. But when I read the European guidelines, what stood out for me is that their language and their tone was such that it basically said it is the job of the government to tell every single citizen to be active in resuscitating cardiac arrest. We're nowhere close to that as a country in the United States, and I think that's a cultural difference. I don't think it's our guidelines.
May I reply to this? We invented the system saving life chapter last round of guideline exactly to point the politician to say, hey guys, wake up. There are a lot of person there in cardiac arrest. So this was the reason, because we were exactly as American Heart target group healthcare professional. We slowly go to the community.
That's great, and I agree with you, Cameron, that you can't make change unless you have people supporting the change that are influential. And I also like that ERC developed that separate guidelines for reading levels that are less. Yes, thank you.
I will say, though, in case any politicians are tuning in, that if we really want to make America great again, we should have our communities involved in CPR.
I would just also add that I think also we have to recall that the stages of experience that our colleagues have in different European countries that what we have right now in America, it's still at different stages. And I think we're still learning a lot about some of the implementation of these mobile technologies and local EMS systems. I think as those stages take more of an evolution and we learn more, I think you're going to see more penetration and more acceptance that will make even easier the path of getting a more broader community support.
Yeah, I agree. And ILCOR is the common ground to exchange these topics all over the world, not only between ERC and American Heart.
Well, I would definitely reiterate that is the interaction amongst the ILCOR councils, learning from how each other have been successful is really a key catalyst for advancing this across the world. So we have another question.
We have 1 minute left.
Thanks for the guidelines. I think it's really exciting how we are shifting away from individuals to a system view when it comes to resuscitation. I'm just wondering, how do we implement such changes on the ground? Because it's very easy to say this is the system, but to really implement it beyond political powers, how do you think as healthcare professionals, be at a pre-hospital or hospital part, how can we play a role in trying to push these systems thinking ahead?
Well, I think in many countries it has been the case that we did this stepwise. Like we had also in the last guidelines this systems chapter, and then we went to our stakeholders, to our politicians, to our organizations even, medical directors, I don't know, and told them, well, this is the ideal system that could be in place if you have a very high resource setting, right? But there's these steps, and what do we have already? Let's make a map of what we already have of this system, and then we can, look at points that we can implement or introduce, right? And if you have more money, you will take, smaller steps. You have more money, less money, you take smaller steps. You have more money, you take bigger steps. But it's a stepwise approach, I would say.
I think that's a great question. I would just add the reflection that when this body of work gets put together, by European friends and also the American Heart Association and volunteers, rider groups, I think it's a synthesis of all the available evidence that speaks to everybody in whatever journey your system may be. Your system may be still under development, may be at a more optimized level, but the guidelines speak to each of those systems at different stages. And I think I would recommend that whatever you are on your journey in your EMS system or your hospital system is like, what things can we do tomorrow in a small incremental step that will build momentum to get more buying and more adherence so you can continue in that process. But for example, if you're still trying to optimize how you deliver, high quality CPR on scene for cardiac arrest care, maybe that's a priority versus considering about eCPR, other things that are more emerging. So just thinking about where you're in your journey, the guidelines tries to speak to each of those systems.
One of the things that's so important, I think, for cardiac arrest resuscitation is it really is a team sport, right? And for those of us sitting up on stage, I mean, we're emergency medicine physicians and critical care, but we also work with cardiologists, and we're dealing with people from many different specialties. And to implement systems of care, which you were saying, well, what do you have to do? You have to be part of a team, right? No matter where you are, whether it's in the community or in the hospital, you have to gather together all the stakeholders who are involved, who are going to touch on the patient. And I think that's what our chapter is all about. We're the only chapter within AHA and within ERC that goes across the entire chain of survival and talks about getting together all the folks that are in these different steps. And that is the implementation piece of it. But I think it's the most important part, because all the rest of the guidelines fall apart if you don't have teams working to implement them together.
I completely agree with Cameron. It's a cake with different ingredients. And we need to convince politicians to, for example, increase awareness in the community. Think about World Starter Day was a very powerful tool to, hey guys, 6th of October, everywhere, all over the world, there is a one-day, special day dedicated to this. In Europe, we also try to push in the school driving license, in the school children training. We try to push the communities, the politicians, but also our colleagues. We need to inform our colleagues about the system. So they are not Han Solo on Star Wars, Millennium Falcon. They work with cardiologists, intensivists, emergency physicians, nurses. It's a team effort, and the team effort is not only in the hospital. It's between hospital and the community or out of hospital.
Thank you. So in a good system, early recognition of cardiac arrest at the dispatch centre is going to be a priority. So it's really desirable to have good standardisation in a control centre, and lots of control centres use really strict dispatch protocols and dispatch systems, and you must stick to the protocol to get the accreditation. So now, rightly, we're saying that we need to ask those not conscious, not breathing questions really early. Is it going to be a challenge to implement those when we're working with systems that require such strict accreditation? Or some of us are. I think many of us, and I think a lot of people in the US would be using quite strict systems.
Yeah, I think that's a fantastic observation, and I would add that a part of the process and the goal for sort of publishing sort of the guidelines and the sort of updated version of the chapters both in the European and the American guidelines is starting to encourage and sort of steer these entities that have either developed sort of proprietary software that help sort of streamline processes in communication centers and 911 centers, and to ensure they are accounting for what we believe is the best sort of body of evidence to recommend them making those steps a little smaller. So I would expect that these entities to, absorb and take that information when they're pursuing their new accreditation standards or their new sort of training materials. Now, for organizations that may not be able to support such a system, they may have their own sort of way of doing things. I would also sort of encourage them to look at sort of these updated versions of the body of evidence so they can sort of account for that more locally. So I think you have two groups, folks that do things internally because that's what they have as a resource, versus folks that use more sort of standardized sort of software, proprietary equipment, that kind of thing.
Christian?
Congratulations for an excellent update, AHA and ERC. You did talk about dispatcher-assisted CPR. Now most of us are using smartphone and we have the technology. Is it a good way to put it, video-observed dispatcher-assisted CPR, so that when we talk about outside hospital cardiac arrest, quality is important, and we talked about eCPR. So what's your say for AHA and ERC about this aspect?
Yeah, so I know within our guidelines, we actually have a knowledge chunk dedicated to video-assisted CPR, and generally speaking, we recommend it. With smartphones, you're absolutely right that it's much easier to implement now than it used to be. Having the technologies at the dispatch center is actually problematic in the US. Not all of them are set up to be able to see the video feed or advise on it. And I think you also need more people, right? And so this gets back to the idea of community involvement, right? Because if you're a lone rescuer, you can't do video CPR, right? You can't even do good CPR by breathing and compressions all by yourself, right? So if you have enough people there, you can absolutely get a video feed as part of that and get feedback, right? And it's like having a virtual coach, and I think that's great.
Yeah, there's still, I think the body of evidence around the element or domain of video as a visual, I think we all believe it makes sense. It's going to add additional dimension of understanding and recognition that we don't have now. And I think you're going to see that more evolve over time. Like Cameron said, there's dedicated knowledge chunk in the chapter. But I think it's going to, in my view, and this is kind of my professional opinion, I think it's going to change dramatically the recognition piece than what we have now. But I think, as Cameron stated, there's still a lot of more learning that needs to happen for having that dimension of visibility into on scene. And that's just more broader for EMS.
In terms of tools, a smartphone you can use with advanced mobile location. So you can use now a smartphone to be geolocated. And this is an amazing resource for EMS. You can call first responder. You can use with a video call, and you can teach in a real time to the bystander that is not able to start CPR on the scene with video call. So definitely we support all these new geek things.
So I think technology is the way, and the AI coming more forward. I think this will be maybe in the next update a more integrated way of doing things.
Oh, I'm sure between now and then, whatever's coming out AI is going to probably have
Change.
New recommendations at some point in the future.
Another small thing, when we talk about the layperson CPR or outside hospital cardiac arrest, but we do have on-duty professionals like police personnels, like fire brigade. They are trained to a certain extent. They are not actually laypersons. So this is the question that do we have some different take for these persons with regards to layperson CPR as on-duty professionals?
Yeah, I don't know that our guidelines are different, but consistently throughout the evidence, when the bystander is a healthcare professional, the outcomes are better, right? And when you have EMS witnessed out of hospital cardiac arrest, the outcomes are better. So there's no question that people who are trained do better. I think that's an argument to get everyone trained and train them better.
I think from a science perspective, we're not quite there to tailor our recommendations to, for example, policemen responding. There's some science accumulating that maybe you should train them differently, tailored courses or tailored education for such people. But we're not quite there, I think. Maybe in the next guidelines.
Yeah, I would just briefly add that when you see sort of at least what's available in the evidence, you will see that systems that have incorporated, like truly incorporated in a systematic fashion, law enforcement or other sort of responders to provide part of a broader system of care, that's doable, but it has to be like an established sort of programmatic, from a system standpoint, not just a one-off here and there. We're training for you to go to a cardiac arrest. So.
Perfect.
Do we have an online question? No? All right, anyone else with a question? We have time for one more question, or? Oh, okay, yeah, so I'm going to jump to the end, the eCPR statement, and I noted for the ERC, they mentioned both in-hospital and out-of-hospital cardiac arrest, but it wasn't clear from the AHA what the recommendation would be for eCPR for in-hospital cardiac arrest.
Yeah, we did not get into that specifically, and part of the reason for that is that with in-hospital cardiac arrest versus out-of-hospital, the trials for out of hospital are actually more prevalent, and we were able to make more of an evidence-based recommendation. In hospital, there's clearly a lot of use of ECMO. I think that it is, there's been many observational studies. What we didn't have was the RCTs to give us some ability to say whether it's the right way to go. And I would argue as an intensivist that in some areas, for example, in cardiac critical care, no one's going to do a trial anymore because they're not willing to in hospital, right? We've already gotten to the point that it's being implemented, and the equipoise has been lost to do a study because of what folks have witnessed. So there, I think what becomes more of an issue is who do you implement it on, right? And that's challenging to tease out from observational studies. And I think the answer to that question also depends on your system, right? And as you know, there are systems that are extremely good and can perform in-hospital eCPR on a broad number of patients and do it effectively. And there are other systems that really have to restrict it to one ICU or one area of the hospital. And so it's hard to make recommendations based on that.
So what was the ERC's perspective for including it?
Nice follow-up question. Well,
You know why? Because somebody put an SCPR on the Louvre, you know?
Oh, yeah.
You remember? So I agree that at the moment I'm not an SCPR man. So yes, definitely there is a lot of expertise. We have several multi-center studies with several different outcomes.
But specifically the in-hospital version of it. So why did you include in-hospital cardiac arrest in your recommendation?
Because we have out of hospital and in hospital in our region, so they put also in out of hospital, not only in hospital. So we put both as a potential treatment, because in some country, like in France, they are very skilled to put ECMO and CPR on the scene, like in the Louvre.
Okay. I think we're out of time. So I want to thank our panel again for a great overview of both the AHA and ERC systems of care. And I'm going to hand it over to my co-moderator to introduce the next session of our webinar.
Thank you so much. After this interesting session, when we talk about CPR, a lot of ethical issues and dilemma, and that needs clarification. And these AHA and ERC guidelines has touched many aspects. So may we request the panelist for the ethics session from AHA, Dr. Ahmad Idris, Jonathan Elmer, and from ERC, Dr. Thierse Desjardins and Johannes Wittig to take it over. Over to you.
Thank you so much. I guess, why don't we start with introductions also, and then we'll get into it.
Okay. Ahmad Idris. I'm the chair of the Ethics Writing Group, and I'm an emergency physician from the University of Texas Southwestern Medical Center in Dallas.
And I'm Jonathan Elmer. I am the vice chair of the AHA Ethics Chapter. I'm an emergency physician and intensivist at University of Pittsburgh in Pennsylvania.
My name is Johannes Wittig. I was the co-lead of the ethics writing group together with Violetta Rafai and Kasper Lauritsen. By background, I'm a medical doctor, currently a PhD student, so was on the mentee co-leads on that writing group. And look forward to this session. Thank you.
And my name is Therese Järv. I'm an emergency physician in Sweden. I'm a co-author of the ethics chapter and also a member of the steering committee for the ERC guidelines. Yeah, who is taking it off first?
I think I am. So Cameron mentioned in the last session that systems of care was the only chapter to span the chain of survival. We are the other only chapter to span the chain of survival. I think same instructions for the online questions for those who want to submit. We're going to be breaking our talk down into some chunks. We're going to start just with a broad overview of why we have an ethics chapter, what it looks like, and what the contents are, and then get into some of the specific topics that we discuss. So, I think for those who are familiar with the AHA guidelines in the past, ethics was not a chapter consistently in the past, and when it was there, it often included more treatment recommendations than ethical content. So we just made a thoughtful and deliberate decision to revive it this time around. And I think that speaks to the question of, so why do we need an ethics chapter at all? And our thought, for anyone in the audience or online who has done resuscitation before, you know that every resuscitation is different, that treatment recommendations cannot cover every possible circumstance, try as we might. And in the face of that complexity, we felt that it was important that healthcare professionals be trained to think critically. We wanted to present ethical frameworks to provide a structure through which healthcare professionals can analyze difficult decisions related to resuscitation, think about it, and to provide a common vocabulary that we can use to communicate when we discuss resuscitation and emergency cardiovascular care and those complexities. So I won't give you an exhaustive list of the topics that our chapters discuss, but some highlights. We talk about shared decision-making as a model framework through which patient-centered decisions can be made under many circumstances. We talk about equitable health care and the importance of health equity, termination of resuscitation across the lifespan with particular consideration of neonatal issues, pediatrics, geriatric cases, and the usual adult patient. We talk about the ethics of resuscitation research, and in the ERC guidelines, the importance of patient participation in research, organ donation, the ethics of advanced interventions such as ECPR that we just heard about. For the AHA chapter, briefly, it's worth mentioning that it looks different than most of the other guideline chapters. We did not follow a modular chunk format because the topic focuses on complex issues, and we did not want to try to distill complex issues down into single bullet points or pithy statements. Similarly, we did not grade levels of evidence specifically. We did perform comprehensive literature reviews with the help of our librarians and the information specialists from the AHA. We did extract those findings into level of evidence worksheets. But for us, what a level A recommendation looks like would be summarized with the quote that I put there, where it is a thought that is supported by multiple ethical frameworks, a preponderance of the existing scholarship, and the consensus of our writing group. And that for us was sort of the stand-in for what would we stand behind like we would in a treatment recommendation with multiple randomized controlled trials. And as I said, the goal was to provide a framework and a common vocabulary through which these decisions can be discussed, analyzed, communicated among professionals. But in that lens, our guidance was not particularly prescriptive. We did not say under all circumstances this should be done or that should be done. Instead, we tried to provide the context through which folks could think through their decisions and discuss them amongst themselves.
All right, thank you. So then it's my part to take over. So I get to guide you a little bit or give you an introduction to the ethics chapter from the ERC. So if we ask similar questions, or actually the same questions, so why do we have this ethics guideline? What are the key issues and how did we actually structure this? So the ERC guideline on ethics is structured. It has 9 topics. You can see 5 of them here. They are advanced care planning. There's, of course, guidance for bystanders, first responders. Then we have also something on research and patient involvement in research. Then something that is new in our guideline, that is recommendations and considerations for how to train ethics for healthcare providers, or ethical reasoning and thinking. And then, of course, termination of resuscitation. But these are just 5 of the topics that we have. We had further ones, family presence, uncontrolled organ donation. We then discussed also CPR in the context of suicide attempts. And we, throughout all of these, we had considerations for low resource settings. And then for all of these mentioned, we had a concise guideline for clinical practice, so something that is useful for clinicians that are supposed to implement this guideline. And of course, we had an elaboration of the evidence. And our structure is pretty much in line with the other ERC chapters, but it is also a little bit unique, and in the sense I would support, our guideline also spans along the chain of survival and is kind of embedded or finds connection points across all chapters. And I think that is where we come to the importance of why do we need this ethics guideline. We address topics that, again, they are embedded or discussed or attached to other chapters, and it just basically underscores that we want clinicians, we want healthcare professionals, we want educators, but also members of the public to be able, according to their level and the situation, to make ethical decisions properly and in an informed way before resuscitation, during resuscitation, after resuscitation. So along the course of all that. And here, when we also, I think, take a perspective in this ethics chapter that is a system-based view, as well as an individual patient case perspective. Now, I think I already pointed to that. Why is it important? I think it's important for everyone to understand that, to make these decisions, to be able to critically think about this and reflect about it. So why have it in one place and not scattered out? That could also be an alternative way. I think it is important to have one resource where you can go, where you can find concise guidance on these topics, a discussion of these topics that are difficult, that need to be reflected upon. And I think that can create then a good foundation for ethical decision making for all the different groups that are involved, and that may be bystander, that may be patients, and that may be clinicians, and all across that, or researchers, and they need that, and it should be available for all who are involved in CPR. Yes.
Yeah, so I think we'll transition then to some of the specific topics, kicking it off with shared decision making in resuscitation.
Shared decision-making is based on the ethical principle of respect for autonomy, also known as respect for persons. This principle guides ethical decisions by ensuring that whenever possible, clinicians elicit and respect patients' values and preferences regarding decisions to refuse, withhold, or withdraw life-sustaining therapies at the end of life care. Decisions around resuscitation can be challenging for healthcare professionals, patients, and their surrogates. These include decisions to forego, continue, or terminate resuscitation, as well as choices between different treatment options. When feasible, the recommended approach to real-time decisions about resuscitation or advanced care planning is a collaborative process between healthcare professionals and patients or their surrogates. This is called shared decision-making. Because full shared decision-making is not feasible during the actual event of cardiac arrest, when CPR must be initiated immediately, the process should ideally occur in advance, such as through proactive discussions in chronic care, emergency, or inpatient settings. Ethical decision-making in resuscitation may be challenging due to the time pressures, limited medical information, prognostic uncertainty, and lack of a surrogate decision maker. This may be particularly true in the pre-hospital setting, such as when choosing to initiate or terminate resuscitation. Although it may be impossible to include all components of shared decision-making in resuscitation, the process itself still has value in supporting patients, surrogates, and healthcare professionals.
Thank you. So from the ERC perspective, we decided to use the term advanced care planning, which is similar to shared decision making. The difference might be that it also considers when your health issues take over and you can't make decisions for yourself, who is your significant other ones to speak for yourself or your values. So we made one graphics. One of the things we also want to stress is often clinicians jump into asking patients to share their values, and we forget the first part, that they need to understand the values first. So we made an infographics. Yes. Yeah. This is for patients and relatives to first think about, what do I know about my health and my diseases, and talk about what's upcoming next if I get worse, what's the options, and also who am I willing to share this with, and who can speak for myself when I get more ill. So this is a very critical part for us, that this is how we should train the patients to do this kind of decisions and discussions. So shortly, the recommendations are like this. We should offer advanced care planning discussions to all patients that are willing to discuss it. And these are not once and for all document. They should be reassessed often. We should also educate before, as I said before. And this should be documented somewhere where they are available bedside when needed, so we actually can follow the patient's wishes when it's needed in emergencies, like cardiac arrest. That's in summary, shortly. Next topic is termination of resuscitation. I think it's interesting that System Save Lives and Save Cares had both, that we need termination of resuscitation rules. Everybody need that, and that's true. But from an ethical perspective, it's not that easy. So that's also one of the key messages. Yeah. So we decided, we understand this needs to happen, but we want us to take a holistic approach on this. And what do we mean by that? So we understand that in half of the cases, a termination is going to occur. So that's a common situation for us. And clinicians really we need advice. But we couldn't find any literature out there supporting how to do this. So from an ethical point of view, what we want people to do is take a holistic approach, considering the patient's values and preferences. I'll come back to that. But why we couldn't really find it, what we are afraid of with these rules is that we miss survivors. But we know that it's easier for clinicians to follow practice and actually, be more consistent over time. But so far, there's no single thing we can trust. So what to do instead? So, we need a holistic approach. We're considering the patient itself, also intra-arrest factors. We don't know yet, but in the future it might be that we will see things. This is a prognostic factor out there. We need to think about, is there any reversible cause we should try to treat? And also, if there is no response to ELS, well, then we know that. And after that, we should offer the whole team around the patient to opt in and to share this discussion. And it had to be a planned manner. So we can say, well, in 2 minutes when we are checking the rhythm again, we're going to terminate resuscitation if no one is against it. If someone is against it, just raise your hand and then go on with CPR and discuss with me, and then we can see if we are making the right decision. So it always has to be a planned manner. It shouldn't be a surprise. Why did we stop CPR this time? So this is in essence our recommendations for termination of resuscitation rules. What did AHA write?
Many pre-hospital care systems worldwide allow healthcare professionals to cease resuscitation in adults, based either on standing orders or an order from online medical direction if patients meet predefined TOR criteria. From an ethical standpoint, whether in or out of hospital, TOR protocols work to uphold the balance of beneficence and non-maleficence by recommending continued CPR in patients who may recover while avoiding continuation of ineffective CPR for those extremely unlikely to benefit. Termination of resuscitation protocols limit bias and uniformly deliver emergency care across populations. Using TOR rules can also further promote distributive justice by avoiding misuse of pre-hospital care systems for non-beneficial transports, which renders them unavailable to the community they serve for the next emergency and exposes rescuers and the public to dangers of emergency transport. Another risk of applying TOR rules is that some patients meeting termination criteria might still recover with continued resuscitation. So these patients would therefore be harmed if CPR was stopped. Thus, TOR rules must be conservative, recommending termination only when the prospects of recovery are extremely small. Furthermore, reassessment and adjustments to TOR rules and policies must evolve with advancing therapies and outcome data. On balance, it is ethical and just for EMS systems to use TOR rules.
Yes, so now we can move forward. We're moving into patient and public involvement and in resuscitation research and research ethics in general. So what did we say about that in the ERC guidelines? So as you can see, it's one of our 5 key messages. So we put it out front. We thought it was very important for us to focus on this. And here, what we say is that we believe that you need to inform the public of emergency research and the regulations that are connected to this. Of course, in Europe, there's of course some diversity in this and some differences between countries. I think we believe the communities that are in these countries where maybe emergency research is conducted should be involved in that, should be informed about that. And then with the spirit of PBI, we say patients or members of the public should be involved in the design, the conduct, and the dissemination of research. And I think I want to elaborate a little bit on this. So what does that actually mean? So the first question, what is PBI and what is it not? And there are different terms what PBI is and how it is called. Some call it community involvement. Some, I think in the UK, they call it PPIE, adding engagement to it. So, but in the end, I think it boils down to this. This is a partnership. So this is a partnership between researchers and members of the public, people who are not primarily involved in research, but have, of course, a stake in this research because they might be affected by what we find out, what we study, and then what we might change. But it's very important, they're not the study participants, they're partners in this, and I think we can be kind of proud of that we also had that in our writing group, that we had a partnership with a cardiac arrest survivor, Paul Swindell, who advised us on many aspects and brought in very new perspectives into what we would recommend and how that would be perceived and understood. So it is important that this is research with patients and members of the public, contrary to research for them. And why is it important? So, as already mentioned, I think this builds trust, this gives new perspectives, and it also makes sure that we have the right priorities. So what matters to the people who we do this for? And I think it's always an anchoring experience. So in the end, what we want what we do in research and cardiac arrest research, especially, that it has relevance and that it has impact. And PPI is, in our eyes, an instrument to do that. So what were the key concepts or key recommendations in the ERC guideline for this? So overall, we say that delivery of high-quality emergency research is an essential component of improving patient outcomes, which is not a very surprising statement, but it's important to remember that otherwise we will not advance. But that this research should also involve members of the public, patients, and that throughout the research process. And that we should promote the education of the public regarding the regulations and the necessity of using, for example, deferred consent for emergency research. I think I can hand it over to you, Jonathan.
Sure. So we did not in the AHA guidelines talk specifically about patient participation in research, but we did talk about the ethics of research and knowledge generation more broadly. And I think our non-controversial overall statement was that research and knowledge generation should be grounded on a solid legal and ethical framework, and I think everyone in the room and online would agree with that. In the US, unlike Europe, where deferred consent is a legal and an ethical option, we're not allowed to do that. Our societal viewpoint is that patients or their surrogates cannot provide consent for things that have already happened. And so we have different pathways for emergency and resuscitation research. One of those is exception from informed consent, and baked into that process are steps of community consultation and public disclosure. And so that, I think, harmonizes nicely with the ERC guidelines and does sort of speak to and ensure an opportunity for the public and community to engage. We also allow waiver of informed consent when activities are no greater than minimal risk. There has been an ongoing debate and discussion in the US about the lines of what is research, what is quality improvement, what requires consent. Do we require consent, for example, to randomize patients to 2 different flavors of standard of care? And that is an evolving issue and is complex. But our writing group felt strongly that while there are many potentially reasonable regulatory and ethical options there, really it is the role of regulators, typically an institutional review board, to make that determination. And we were concerned about the possibility that individual investigators would arbitrate their own protocol and say, this is quality improvement, I don't need to ask anyone about this, I'm just going to do it. And so our call for researchers was not, don't do waiver of informed consent or don't do quality improvement, but do go through the important pathways that ensure research protections and do it the right way, as opposed to trying to bypass those, particularly when the intent is to create generalizable knowledge, because that process of knowledge creation and dissemination is a hallmark of research. And if you're doing an activity with the goal of generating new knowledge, you should follow the appropriate regulatory pathways to ensure protection of your human subjects and engagement of your communities for which you are generating the knowledge or doing the research.
So now I guess we're coming to the difficult part of this guideline, and that is how to use the ethics guideline in patient care and courses and how to actually get it there. So we imagine this as a little bit more of an open discussion. And I think we have some points, and I'm not sure, Tessa, do you want to start what we thought about it? Because we thought a lot about it.
Yeah, it's as you said, it's a bit strange to have an own chapter for ethics, because how can you do resuscitation without ethics? So, but on this other side, it's quite nice also to have that. But we really need to, all of us doing courses and lectures need to integrate this ethics chapter in scenarios. Even how often do you, when you went to a CPR course last time, did you actually focus on termination? Or there is a decision to not do CPR, how to handle that. So those kind of things is how I would love to see this chapter coming alive. How would you like to see?
Yeah, I agree with that. I think we were also mindful as we developed this chapter about the importance that we were not simply writing a document to go through the exercise of writing the document. Not that that process was not wonderful and fulfilling, but we didn't write it just to write it. We wrote it because we wanted to provide healthcare professionals and lay people a document which could guide their training, guide their education, and guide their thought process. So I think termination of resuscitation is a great example. In our discussion of shared decision making, we also talked about other possible pathways through which you can engage a surrogate or a proxy in something that still respects the patient's autonomy. So, as a concrete example, in the sort of acute abrupt emergency setting, something like informed non-dissent, which may be as simple as considering the best possible option and making a recommendation of the best possible option, and then listening actively to gauge whether or not the surrogate decision makers object to that. I think given the information that we have available to us right now, the right thing would be to stop CPR rather than trying to transport to the hospital, because the chance of a good outcome is very small. And that is an option when there is one strongly preferred decision, not a large menu of options from which to choose, and something that is a learned skill, which is best not improvised while delivering chest compressions at the bedside or on the floor. And so our hope was that portions like that could be incorporated into education and into practice. Family presence during CPR is another one, debriefing another one, and that by providing this structure and this content, we would change the way some of these basic skills were taught. So it's not just about push hard, push fast, but also about some of the decision making that involves. We were going to call on the audience for this part, but we can spare you and
thank you so
commit
much,
to the
the AHA and ERC group, for updating on such an important topic. I think it's challenging, but you did a good job. Any questions from the audience? Yeah.
We didn't plant the questions.
Thank you very much for a nice presentation about ethics. Is very big word, piece of the cake. How is difficult to merge in Europe and US our diversity? Because I work in UK, I live in Italy, and I know Europe, how it's different in palliative care, advanced care planning, donor temporary resuscitation, and many other things. So how we can find an average between north of Europe, south of Europe, US, east of us? It's a challenging question, I know. How you can sort it out? How you wrote about this in your chapter?
Yeah, thanks for the question. I think it is a very important question. It's one of the first questions I think we asked each other in the working group and that we discussed constantly. Because values, preferences, they might vary across regions. There might be cultural differences between regions, religious differences that influence all these things. And I think what we tried to do is not create an average of what is the average decision, but create recommendations or framework that could be used in an individual level, and that it is on the individual interaction, so the physician or the healthcare professional interacting with the patient to then take a decision together that takes into consideration the respective cultural, religious, or other values and preferences. I hope that answers your question.
So I think you guys did a great job in terms of talking about the ethics of advanced directives and limiting resuscitation, termination of resuscitation. I'm curious how much you discussed within your chapters about post-resuscitation limitation of care at that point, right? And as a critical care physician, the discussion that I most often have to engage in is about goals of care, and sometimes that leads to withdrawal of life-sustaining therapies in patients. As you guys all know, that's the reason why most of our patients die, because our technology has gotten so good that we can keep folks alive for forever in many cases. And so, the tool that Therese showed I thought was excellent. But one of the things that seems to be really important in the post-ROSC setting is what disability would that person be willing to live with? And I find so few people have thought about that. So how much discussion was there around that? How much, did you advise in terms of dealing with neurologic disability, which I think is so different than other organ injuries, not the least reason being we can support other organs and we can't support the brain in the same way?
So I guess I'll give the AHA's answer first and then pass it over. We talked about it a lot. We have a section on termination of resuscitation, but that is separate from the section on shared decision-making more broadly. And I think what you're describing of the post-acute decision-making is really well-suited in general to shared decision-making. We have content about medically ineffective therapies and how to navigate those situations, to the portion of your comment about the ability to keep people alive forever, which is not always true, but often is. And we talked about the quality of recovery. I think that is a particularly complex and fraught topic. We discuss a little bit about domains of recovery and the difficulty for healthcare professionals and for surrogates who are trying to represent the patient's values and preferences and apply the principle of substituted judgment to actually understand what would be an acceptable level of disability. You know the disability paradox well, but often folks without disability think that living with a disability would be a fate worse than death until they have that disability, and then they're glad to be alive. And so, I think those are pieces of the puzzle. Those are considerations. I think most of the content of our topic about decision-making is not TOR specifically, but is about the breadth of decision-making. And obviously, in the context of neonatal or pediatric resuscitation, there are nuances there which are very different than the general adult population. You know this as a pediatric intensivist, but the default approach and how we apply those principles, how we apply the zone of parental discretion in the U.S., all of those are in the chapter and are discussed. It's not easy to give it a one sentence, our strong recommendation is that healthcare professionals should, but the narrative content is there, and I encourage folks to read it.
You did talk about the advanced care planning, and at times it happens, it's an emerging concept at many places, and you may not have clear directives in the beginning, but after first return of spontaneous circulation, and then they realize that we should go ahead with ACPs. So does the guidelines mention about it, that if something happens again, or there's a rearrest, how to go about it? You did talk about shared decisions, so does it become part of some guideline?
We don't specifically situate advanced care planning in time like that. I think the best time is in advance when patients can represent their own wishes, and then updated frequently. I think looking at the continuity of care after an initial resuscitation, there are certainly opportunities that are ethical and reasonable to choose to limit additional aggressive measures, including resuscitation again. But we didn't specifically talk about that circumstance.
No, and I just want to add, I agree with everything you said, and we had the same discussions. We also had an ethicist in the group to make sure that we kept the ethical issue central, not only the medical issue. And the more I know, the more I read up on this, the less is true. I mean, and we get better and better on prognostication and saving lives. So for us, it goes back to the patient's wishes and values and preferences, and also involving the relatives in this. Because if it's the final year in life, maybe that's the only person knowing what kind of life they are willing to go back to. So that was a central thing for us, that if we don't know, at least the patient or that significant person for the patient might be the only one having the answer. So that was a central thing for us.
My question was about research design. I was interested. I got the impression there was a bit of difference with regard to public patient involvement between the US and UK. I think it's fair to say in Europe there's an absolute requirement for public patient involvement in research design. Is that the case in the US where there's that expectation?
I don't think it's absolute. I will say that most of our funded research comes from federal dollars, and community participation at community advisory board, things like that, are increasingly expected by our funders. We did not think about patient participation in research in our writing group and say, nah, that's not for us. It was not one of the topics as we sat down that we said, this has to be in, and it's a long chapter already. I'm pretty sure that the AHA would have, grabbed the cane and pulled us off the stage if we kept adding sections. So it was not a thoughtful omission that we said, we disagree with this as a principle. It was just, we couldn't include everything and address everything.
I think I can take a liberty because both the groups are there, the SOC group and ethics. We did talk about the extracorporeal CPR, and we did talk about the ethics part. There's some literature which says that sometimes eCPR may be required for organ retrieval. So how will we engage both the things that during the cardiac arrest situation, eCPR versus eCPR, we know that the outcome may not be so good. We are talking about TOR. Should we go ahead? Is there something, directions for organ retrieval somewhere from this side?
So systems of care actually did include within our organ donation knowledge chunk a guideline that essentially said that using eCPR or doing resuscitation for the goal of organ retrieval was recommended in the setting where that was common practice or prescribed within the community, because not all countries and not all communities, not even all states, we have divergences state by state on laws of what is acceptable and what's not acceptable. And so it really depends on the system you're operating in, but there are definitely some systems out there where studies have been published on organ retrieval using eCPR to preserve those organs. And if your healthcare system is willing to do that, we think that preserving organs is a valuable thing, and we think it's a good idea as long as the community is bought into it.
So did you touch about this aspect in the ethics component that if the aim is for organ retrieval, probably not for the survival, how to go about it?
Sure. So we also talked about that. I think both of our guidelines, Will, and I'll pass the mic over for a moment. I think we agree that it can be ethical and reasonable to use extracorporeal perfusion to support what's sort of conventionally called uncontrolled donation after cardiac death. Under certain circumstances, as was said by systems of care, and with precautions. So as an example, if eCPR were available as a resuscitative technique to save a life, then also using it after all resuscitation has failed would be reasonable. It would not be reasonable to create a system that could only do extracorporeal support for uncontrolled donation, but not offer it to patients as a life-saving technique in the moment. That's a specific example, and we enumerate a number of considerations and precautions to ensure that if this is done, it's done in a way that is ethical and widely viewed by both the ethicist and public as acceptable.
So in Europe, we have so many countries and different laws, and we need to follow them. So in our guideline, we just wrote that we support strategies to improve organ availability, but also we wrote that termination of resuscitation rules should not conflict with organ donation. But again, it goes back to following the patient's preferences and values. If that's what they want, we should support that. So it doesn't really focus on eCPR only. It's more like the bigger picture that we should, of course, strive for more organs and not make conflicting rules. You want to add anything?
Great job, great work. Appreciate the thoughtful approach to the content and the information that's been shared. I had one observation that I was hoping to get a reflection from you also. I thought in the chapter the thoughtful approach about the distinction between what's quality improvement or thinking about sort of research and sort of that engagement. And I thought that was very thoughtful. Question is thoughts on any recommendation how sort of researchers should be taking that into account as they're thinking in future studies or future work. What is the sort of the main takeaway point that you'll want them to take, right? Because a lot of folks are doing all kinds of different work, and I think the what's reflected in the chapter is very thoughtful. It makes a lot of sense. It's just kind of what's the big takeaway point for researchers thinking about a new project or how they approach their questions?
At the moment, community consultation is only necessary after a study has been designed and about to be implemented. However, many people think that we should engage the community before a study is designed to allow the community to express their thoughts about the study being considered itself. And I think there's a lot of virtue to that idea.
Small question, which is online. Which will be the correct place during CPR for PPI? I mean, some way, some designated place, or what do you suggest in the guidelines?
So when to do PPI?
When and which place?
I think that depends also what you're studying. What is it? Are you working with survivors? Are you working with? I think the actual cardiac arrest patient. Of course, this is a sudden event. We're not studying a chronic disease here, so it's challenging to do it. Actually, we're recommending it. However, I think where to start is important. The starting with PPI is, first of all, acknowledging that it needs to be a consideration, and it can be included, I think, at the outset. I think it should start with prioritization. So having patients have a stake in how to decide, or they have a stake already, but having them involved in the decision what to do. And also then what to invest in, and then also keeping it on for the actual conduct and also then the dissemination so it reaches the community.
So more of a contextual scenario where you like think of this aspect. So remain curious. More questions will be there, I'm sure. Those who are listening to us, check on the guidelines. There will be too much material to understand, to capture and improve the patient care. And I will request Professor Neumer to give a concluding statement.
Well, on behalf of my co-moderator and myself, we want to thank all of our panelists, both for the system of care panel and our ethics panel. Let's just give them a round of applause.